busy days to join us. So just for your information, this meeting will be recorded and we can have questions at the end of the session. And you can always send questions you have to the chat, and we'll attend to those at the end of the session. So today we have with us Gabriela Matouskova and Andy Turner from Hope for the Community organization, and they'll be speaking to us about what research has done for us. And in this seminar, they'll speak about the positive use of research and evidence and how it has led to positive outcomes for the community and different organizations. The UP program was developed through a collaboration between social enterprise and academia, and will be used as an example of how research can be used effectively. And now I'll be handing over to Andy, who would take us to the first session. And yes, thank you for joining us today. Over to you, Andy.
Thank you. Thank you, Michael. Hello, everybody. It's a pleasure to be presenting today, and thank you for attending. The title of the talk is "What has research done for us?" Some of you may remember there's a famous Monty Python sketch where it's what have the Romans done for us? Hopefully by the end of this presentation, next slide please, Gabriela, we'll be able to present enough evidence to show you that how we've translated the research and extended it beyond academia into delivering real-world impact. The first, so yeah, I'm Andy Turner. It's 28 years now, Michael. Yeah, that information we sent you is 3 years out of date, and those three years have been really tiring and stressful because I've had one hip and one knee replaced, and I'm due for one hip and one other knee. So all lower extremities will be replaced. So those 3 years have not been kind. So this presentation's in 2 sections, and Gabriela will be presenting. I think what we're all here today to really listen to is the real world impact of the research, and in particular the HOPE program. So I'll be briefly running through the why research is important for developing interventions, some of the tools and the frameworks that we've used, and then the collaboration between the academia and the social enterprise spin out, which Gabriela is the CEO, and Gabriela will be presenting some impact case studies, some real world impact case studies, and in particular you'll be hearing from the voices of participants who've used some of our interventions locally. And beyond, it'd be great if some of you who are in attendance today think, I've got an idea for testing a support or intervention for people living in Coventry, people that you work with, groups that you work with, and you would be inspired to think, yeah, let's get in touch with H4C and talk to us about some of your ideas. Great. Next slide, please, Gabriela. So just I was asked to give a quick definition of research. This is the Frascati. Some of you may remember that as I think 1980s bottle of, is it Greek wine? I'm not sure. I'm not a wine drinker, but that's what always springs to mind. But they provide a formal definition of research which universities use. And applied research, which is what we'll be presenting today and showing evidence of, is primarily directed towards a specific practical aim. Experimental work, research that we do some of. So for instance, we might experiment with the length and the delivery and the timing and the messaging involved in some of our digital interventions to see which is more effective. And then basic research, which is, as it says there, is research without any particular application or use in view. And that's not something that we've been involved in particular in this program. And when I reread this definition, There's a sketch show from over 30 years ago. It's called The Fast Show. So you can find it on YouTube if you're interested. But each week they had the same sketch of a university professor who would be describing some of their research that they did. There are other, not so positive viewpoints about academia and research. Albert Einstein said, continually being forced to produce scientific writings, creates a danger of intellectual superficiality. And then more recently, Elon Musk puts it a bit blunter, as Elon Musk is wont to do. Most PhDs are irrelevant. The number that actually move the needle is almost none. That was his response when asked why didn't he take up the opportunity, I think, to do a PhD at Stanford. Next slide, please, Gabriela. So you may have heard this phrase, publish or perish. That is, the lifeblood of academic life. Careers are built and taken away on the basis of it to publish high quality journals. The UK government allocates up to £2 billion worth of funding per year based on academic outputs. And there was an assessment introduced in 1986, and it's every 5-6 years. The university research departments are recognised and rewarded depending on how many high quality publications they produced and the research environment. And since 2014, the government introduced another element of the research exercise framework, which is universities have to now show what impact that their research is having, which is obviously music to our ears, because that's what we've been trying to do in the 28-30 years that I've been working at Coventry University. And so it's basically the universities have to submit impact case studies demonstrating real world impact. And Gabriela will talk about that, how we've managed to do that in the last two REF assessments, 2014, 2020, and how we're attempting to do that in 2029, I think the next REF assessment is. Thank you, Gabriela. If you could move to the next slide. So I'm going to very briefly talk around some of the frameworks that we've used, how to develop the HOPE program, some of the frameworks and the methods. And before I describe some of the components of this framework for developing complex interventions, I'll just share with you the story, because running throughout this presentation is how our work has been informed by the voices of patients, carers, family members. So 30 years ago, no, it's 28, I keep adding 2 years on, 28 years ago, we were a research centre which evaluated other organisations' interventions. We applied for funding, or we were commissioned to evaluate and report back on the success or otherwise of other organisations' interventions, such as Arthritis Care, the Multiple Sclerosis Society. And then I was really passionate about this area, and I was one of the researchers in a huge team. I was doing lots of interviews with participants, started with arthritis and then general long-term conditions. And I got lots of feedback about what worked well for the interventions, what didn't work quite so well. I also did some research on the facilitators, the coaches of these interventions, and was really inspired because they were peer facilitators, and I was really inspired about the work they were doing. And so then I trained to become a facilitator of something called the Expert Patients Program, some of you may be aware of. Because I was loving the research I was doing, but I also wanted to give something back in terms of practical application, in terms of becoming a facilitator. So I attended as a participant. That was the process, because I had a long-term condition, hip and knee osteoarthritis. I attended as a participant, and the facilitator was a man called Dave McCarthy, and he's central to the the work we've been doing ever since that day I met him. So he was a person with a long-term condition. He was the facilitator. I got talking to him during the break, told him what I did, and from that period for about 2 years, he said, what you've collected all this information, you've researched all these different interventions locally, nationally, internationally. You've got, your department's got so much information. Why doesn't Coventry University develop an intervention? I said, but that's not really what our research strategy is. Anyway, he was so insistent that he spoke to Macmillan Cancer Support, where he had contacts, and that's where we started from developing the HOPE program. So it was down to a person living with a long-term condition who had connections both locally with the council and the Carers Association, but also with Macmillan. So it was his inspiration that actually led us to start thinking about, let's develop our own intervention. So that's where we come in now with the MRC framework. How did we go about developing our own intervention? We obviously drew on the the existing literature. Many of the studies we published ourselves. We both knew what the strengths of the existing interventions were, and some of what the participants would describe as shortfalls or weaknesses. We did a series of co-creation workshops. The first one was with Macmillan, so people living with cancer, the carers, the health professionals, the surgeons, series of qualitative interviews. We then built the components of what the self-management intervention might look like. We started off in person, and we drew on many of the as I say, so the interview findings that we gathered, and we went through a whole process of piloting. So we developed the intervention, we built it, we tested it within a feasibility trial context, a pilot study. So Macmillan wanted just to see whether we could recruit to it, whether the participants valued it. And so we ran one course in Coventry. Participants were recruited from UHCW, and one in Manchester. The feedback was generally positive. There was some feedback to improve certain aspects, and that started off a long-term and it continues to this day relationship with Macmillan Cancer Support, who still run the Hope Cancer program. We have then published some feasibility studies, where it's really important to do a feasibility study before you go on to a big trial, because part of the feasibility is that if you build it, they will come. That's not always the case. So you could stop at the feasibility stage and you haven't used too many resources in terms of funding and time. With the Macmillan course, we went from small feasibility trial to a small randomized control trial. And in other programs that we've developed, we've gone feasibility, and now we're applying for large scale funding. What's also important as well is to do qualitative process evaluations. If it works, if the intervention works, which is great. So if we see a reduction in anxiety and depression, we want to know why we've seen an anxiety in reduction in depression, and that's why the framework describes complex interventions. These are complex interventions because they include peer support, peer facilitator support, evidence-based behavioral techniques, and group processes. So it's really a complex intervention, and it's difficult to tease out what's the main mechanism of change. So next slide, please, Gabriela. So this is, for all of that work following, and it's an iterative process using the MRC framework of doing the co-creation, testing, getting feedback, improving, retesting. This is the basic components and content of the self-management program. And what we think makes the whole program different and unique to some of the interventions that I was researching 28 years ago is their model of supporting people with long-term conditions was focused on a negative symptom cycle, breaking the negative symptom cycle. So pain might lead to low mood might lead to isolation might lead to, you know, to frustration, and around that negative cycle, participants find themselves stuck. When I interviewed many participants and asked them what they found useful on these types of programs, often they would focus on two things really spring to mind, which we used to develop the whole program. Is one of them was, I've become more hopeful being on the course. And then when I asked them further to explain why did you become more hopeful, it's because being with other people, seeing the facilitators who are often people with more visible and severe disabilities than themselves, set up the room, deliver the intervention, and be really supportive, seeing other participants improve, that really gave them hope that they could make positive changes. And then the other one was that also being with other people in a similar situation, being with peers, really kind of help reduce anxiety, that we're all in the same boat, or I'm not unique. I thought there was something wrong with me because I'm experiencing all these issues. Turns out everyone else in this room is experiencing the same issues. So we looked at something called a theory called positive psychology, where that was running through the theoretical underpinnings of the program and many of the activities, such as focusing on personal strengths. So it adopts the what's right with you rather than what's wrong with you. And then we had gratitude activities and other activities in there which really focused on like an upward spiral of positive emotions rather than breaking the negative the negative cycle. Next, thank you, Gabriela. And this was a participant from a Coventry participant who went on the first HOPE program, the cancer one in Coventry, when asked what they took away from it. And it really, it's such a lovely quote. And we've got thousands of quotes since this first one, but I always come back to this because it confirmed at that stage that we were going along the right path in terms of building positive aspects, the positive psychological aspects of the program. The course gave them hope for the future. Next slide, please, Gabriela. So you heard me talk about Dave McHattie. So Dave, it was his inspiration and dedication that convinced us at Coventry University to develop our own program, the HOPE program. And that's obviously, you've heard me describe, HOPE is a critical part of the journey of a person with the long-term conditions. After we've been delivering and running some small local projects and national projects, it was also Dave's idea to set up a research spin-out company. He'd heard of something called a social enterprise or community interest company. They were very new at the time, and we spoke to at the university, our IP, intellectual property and commercial lead, and we set up a community interest company with Dave, Tina, Wendy, and Vicky. Tina and Wendy were local facilitators for the Parents of Autistic Children program, and they delivered those programs over many years. I think they delivered about 30 courses. And then Vicky Harker was a person living MS, and she still to this day runs the MS HOPE program. So now I'm going to pass you on to Gabriela. Now I've kind of very briefly described how we've gone from research that we were doing with other organizations to research of our own HOPE program to what we think is the real exciting impact of the program is the work that now Gabriela and the team have taken on through Hope for the Community. Thank you.
Thank you very much, Andy. I've met Andy probably over 10 years ago, and I sort of dabbled in and helped and supported at the time working at the university, and it was a course that Tina and Wendy were running, one of the last parents courses that I visited in the last session, just to sort of thank them for doing all the hard work over the years. And I was able to join the session at the last minute, and there's an exercise they do focusing on people's strengths, and they sort of pass a piece of paper where they draw their hand and people write what they think the other person's strength is, and then you receive your little hand with what everybody else thinks your strengths are. And that was really powerful. There were tears, there was laughter, and I've seen the change in the parents over the 6 weeks, and I just thought, why isn't there more of this? And so 4 years ago, I've decided to quit my job and give Hope a go. And it was just before the pandemic, and we knew that one of the things that we wanted to do was scale and further develop the HOPE program. And so over the last 4 years and nearly 10 years into existence of the social enterprise, we do focus on empowerment, so give people the skills, knowledge and the confidence that Andy described. We do focus still on self-management of long-term conditions, but we know that long-term conditions don't affect just the people who live with them, but also their family, their friends, colleagues. So it's also focusing at carers and the wider family, and inevitably, due to the pandemic, where a lot of our provision that was delivered in person had to stop to keep people safe, we have pivoted to digital and are very much predominantly a digital social enterprise at this moment. We talked about the impact, so we have since the start reached 28,000 people, but we all know in this room that it is not just about the numbers, that this is just one part of the story, is that we are really focusing and drawing on the research. So again, what has research done for us is what actually changes. So focusing on those outcomes, what does improve for people when they go on the courses, what improves for the systems, what improves for us as a society. And we try to, where possible, continue developing not just the programs, but also the research and the evidence base around it. We can't do it alone. There is only 5 of us in Coventry, but we are very fortunate that the way the whole program is scaled is through partnerships, and we have a train the model. And we have got a range of partners all around the country who either some who connect people with very common long-term conditions, and some where we connect people who have never met anybody else due to the rarity of their condition. But that's where sometimes the digital delivery enables us to do that. Now, we've not forgotten that where it's all happened is at the centre. Coventry, as it's known for many things that have been, it is also known for the whole programme, and we're very proud to have been able to deliver projects locally. And in this next video, I will show you stories and impact that we had with a local project that was funded just as we were going through the pandemic from 2021 for 2 years, funded by NHS Charities Together in partnership with Universities Hospital Coventry Warwickshire Charity, supporting self-management of people with long-term conditions. So I will let them tell you what difference the programme has made. So you've seen in there a snapshot of one of our projects, and we were really proud within this one because it really showcased the flexibility that the whole program and the work that Andy has done over the years has enabled us to use some of those elements of those research methods to put something out there that would help those people who didn't have any support at that time, and that was the long COVID. It took us from this timeline, you can see, it took us merely less than 6 months to co-design and build and put together a course that we tested and trialed on 22nd of September in 2021, and then continuously evaluated throughout. And we are still running these courses today. We have reached over 3,000 people with long COVID, those, you know, predominantly women who are disproportionately impacted, people who lived in the areas of deprivation. And it was really interesting for us to, as part of the project, where possible, to also publish studies, including co-authored by our participants, to sort of highlight the positive impact that the program can have. But we know those studies are often not possible. However, we very much value, because when you work in health, the evidence base is really important, is that we just don't look at those sort of gold standards, potentially time consuming from time to time. We value them, we can't do them all the time, but we're very keen to also collect clinical measures that are recognized and recommended by the teams when we co-design. And the short work at environmental wellbeing scale is our main measure, because we know that a long-term condition impact people not just physically but also mentally, and we're really keen to see the results over a longer period of time. We've got results over 6 months, like you can see here, and as far as 2 years, with that sustained positive well-being being maintained throughout that period of time. But it's not just about that. We look also beyond, how does it impact the system? So is there possibility that people use their GP visits more effectively, because they can't always reduce them given that they live with a chronic illness, but in some cases we see GP reductions. How does it impact their work? Are they able to get better adaptations at work or return to work quicker? And how are they connected together? So again, for us, some of those methods we have translate from research to work in our day-to-day. But more importantly, like I said, we can't do it together, and the program has been really flexible for us, the way it's been set up. We had to learn and change lots of things. We run in-person courses still around the country. This is a group of about 50 of our facilitators. Down in Devon, there's over 100, and Macmillan have got over 400 facilitators trained around the country, and we are really grateful that they share their impact and their reach continuously with us. Like you've seen some of the local work, so you've seen in the video as well, Sinead and Gordon, who was one of the facilitators, running it in partnership with Life Path Trust, so adapting the program for citizens impacted by learning disability, and those cohorts are now also being run down in Devon. And then also working with the voluntary sector. I'm very passionate that we work in partnership, so it's running sort of a 3-hour version, much more accessible, to sort of reach those where we can translate certain materials and do it quickly. But as I said, we moved to digital, and that is probably about 90% of our delivery at the moment, alongside the in-person delivery. We do obviously have built the digital technology around it being asynchronous. People don't have to be live at the same time. It's very flexible in terms of groups or individuals. For some people, being with others isn't necessarily what they want to do. They want to do the course straight away on their own. And we've identified that one of the barriers to access was actually data access, and the apps and the way the program is delivered is also accessible offline. And we've built a community where people can join after each of the programs to continue their self-management throughout. We've got 14 co-designed digital programs at the moment. They have been externally accredited by Kismet and are aligned with clinical safety, NHS clinical safety compliant. And so much so has been our pivot to digital, recognise that in this year we are a finalist in the Tech for Good award for Social Enterprise UK, so a national recognition. And so fingers crossed we can put Coventry on the map. But when we've built the technology, we know that technology needs to be maintained. And I'm just going to quickly play this very short video and then explain a little bit more. So I play from the beginning. So what you've seen in that video is rockets actually landing. It wasn't played backwards, but that is SpaceX. It's a way of repurposing rockets without not just sending them to space to take a satellite, blow up and not come back, but actually created them to come back and be reused for next time. And when we were building our digital platform, we did exactly the same. We have built a platform that could be used by any organization to develop any type of program for any type of community that they want to work with, to again utilize all that research that we have been doing over the years to bring people together or individually put content together, use some of our content, and really flexibly. We have worked with PhD students at Coventry University, delivering work as far as Indonesia and more. And so really my call out to you is, if you know, we have been in this process, and what has research done for us, it's more about what our research can do for you. If there's anything that sort of strike a chord with you, really be keen. If you're keen to develop any ideas, if you're willing to test stuff in the community, if you want to use digital, we're really open to work with people, because we have built the technology, we maintain it, and we want to make sure that as many people benefit, not necessarily just through the whole program, but through a lot more, because there is a lot of work to do. And if you were to ask you why, as to why you should go down this journey and all this work, well, this is one of the quotes we received from one of our participants on the cancer program. And I think for us, knowing that what we do changes people's lives is really where the impact of the research translate into now. But we're out of time, so we're going to leave it now to questions.
Thank you very much, Andy and Gabriela. That was a very useful session, very informational. It's great to see the work being done and to see how useful research has been in helping you develop your work at Up for the Community. So now I'll be taking questions. If anyone has any question, if you have any question, please do not hesitate. You can raise your hand or put it in the chat, and I will carry that out. While we're waiting, I do have a question around digital exclusion. Seeing that you've transitioned to you know, having most of the program delivered on the platform, what about people who, you know, do not have the expertise to use digital software or to access the internet? How can they be carried along in Up for the Community?
So obviously we still have in-person programs where possible. We run those, so it's that flexibility of choice. We know from the outcomes comparison that whether it's digital or in person, they are comparable. So it really what matters to the person and what is possible for them in terms of their mobility access. But of course, we work in partnership with organizations. So we always try to find the best right model that works for the people they support. And of course, we know that within Coventry, there are wonderful programs like Cov Connects and others. And because we have co-designed the platform with our users right from the onset, it is very user friendly, but we appreciate that there needs to be some extra support. But the offline access, that sort of support that can be provided, and the onboarding we provide is really there. But we know for some people just digital isn't right. Of course, that's why we have those other alternatives of delivery where possible. And it's really that partnership with our partners to understand what will work the best for them.
Yes, thank you very much. That's quite helpful. Still waiting for questions. If anyone has any question. Okay. Yeah. Rachel. Yes, please. Go ahead. 1 second.
Thank you.
Okay.
Yes, yeah, I can speak now. Thank you. Thanks, Gabriela. And I heard you speak last week at the public health meeting as well. So it's really interesting to hear, you know, the sort of extended version of this. Clearly, the programme has been applied in lots of different situations and for lots of different groups. So it's a question in terms of how do you decide where to apply it, where to develop it, and are there any times where you've said actually it's not going to work there?
Andy, do you want to answer that one?
Yes, what's the phrase that never work with children and pets? A lot of our work, nearly all of the research was done with adults over 18. There are particular challenges working with young people, especially now, given the rise of social media and how they consume education, entertainment. But so I've always been reluctant because we've got no expertise, and there are other experts out there. But Gabriela through H4C has worked with some local youth groups to start dipping our toe in the water to see what needs, what fundamentally needs to be different, and it could be, radically different. So Gabriela, if you want to speak about that work you did locally.
Absolutely. So we worked with Positive Youth Foundation. They helped us co-design a program for 16 to 18-year-olds. It was mainly converted our content to be snappy and quick and video based and TikTok type format. And that was looking specifically at groups with long COVID because they felt particularly isolated. But in terms of, we know where self-management sits in terms of those. So we also know that, people in crisis will not benefit highly potentially from the program. However, Rachel, sometimes we cannot be too prescriptive as to who comes to our programs, because sometimes this is driven by the lack of support within specific area. It might be the timing. So where we develop new is we consider that carefully with our partners, whether and generally about 60% of the program is consistent, and then 40% is tailored to a specific group condition or other. So again, we undertake the co-design, but we would say that where self-management is not applicable is for people in crisis, to make sure that we can really support people into activating the knowledge, and we're not setting them up to fail. So I think it's pretty much limited by where we want to apply it. However, we have seen throughout the last 4 years possibly groups of people that we have not seen on our courses before, but that's probably due to the way services, waiting lists and everything else operates. But always the decision is we try things. If they don't work, we will not continue. If they do work, we will make sure that we improve them.
We describe the program as therapeutic, but it's not therapy. We're clear in the recruitment materials that as Gabby said, if you're in crisis, or if they're included as part of a study in one of the outcome measures that we use shows that they're at very high level clinical levels. Either the organisation who's running the programme or H4C or both will contact that individual and check in with them and say, this is self-management, just kind of safeguarding and then also recommending that they seek more formal help. And often they're already seeking formal help, and it's the peer support that they've not been able to access, so they continue with the programme.
Thank you.
Great. Thank you very much for that. Now we have Natalie.
Oh, hiya. It's more of a comment than a question, really. It's just to say I have personally attended one of the HOPE programs, and it was just to say it was just one of the most positive experiences I've had. It was quite an emotional journey, but there's a really good balance of kind of TED Talks, written information, and there was the coffee chat, which was all online because it's during COVID. But it was really reassuring, and kind of that peer-to-peer support, like you were saying, was so important, and just having that exposure to other people who were kind of going through a similar experience, and having the facilitators who could relate to that as well was so important. So it was just, thank you, really. Yeah, what a difference it made.
Thank you, Natalie.
Thank you. Thanks for sharing that, Natalie. Well, one of the other quotes, I think this came out of the Parents of Autistic Children course all those years ago. It was like there was tears of laughter and tears of sadness. So as you said, Natalie, it's that balance of obviously people come on the program because they're experiencing, some challenges, some quite severe challenges, but always that gentle the kind of reframing as well. Can you, and sometimes obviously participants can't, but can you kind of see something positive in, hope for the future?
Yes, thank you very much. Good to hear that. Next we have Audrey. Yeah, you can unmute yourself, I think. Yeah.
Thank you. I can unmute now. It's just to follow up something that Rachel said. Actually, it's more about the accessibility and you saying where not to go. But have you found any significant people or groups that have dropped off as it's gone along, and what are the kind of the natural drop off, and what is it's not quite working with that cohort? So, for example, I'm thinking housebound patients, elderly patients, long-term condition patients.
Yeah, sorry, Gabriela, go on.
No, actually, in terms of housebound patients, we had a program specifically for a group of them, and that was the only time they were actually able to connect with somebody else. But we have got a natural drop-off in terms of people sign up. It's a free program, so there's a drop-off there from sign up. Then we have certain KPIs in terms of progression, in terms of we have monitored where the outcomes improve the most, sort of halfway through the program, and then they sort of improve continuously, but maybe at not such a peak. So we have got a lot of nudging and encouragement in the facilitators follow-ups in sort of to try to get that engagement into those people to benefit the most in terms of doing the maximum sessions for their dosage. So there's a lot of work that has gone into us following up where does that biggest happen, and do people actually need all of the sessions, or can they just go through halfway through the program? So we have got some data on this. Of course, we're looking how to improve that, but it is very individualized, and Andy will be able to probably tell you a little bit more in that sense in terms of what our plans are to do some future work.
Yeah, I mean, yeah, it's a really important question, and digital health self-management, cognitive behavioral therapy providers, mental health providers are, it's the holy grail. How do you keep engagement optimized so people benefit? And yeah, we're constantly applying for funding to look at how artificial intelligence might help support our facilitators, identify those patterns and personalities of participants who are more likely to drop out, so our facilitators can provide more support, say, early on. I think we do find a difference if they're a carers or a parents program, because they're they've got lots of other responsibilities. It's not just looking after their own health, they're caring or parenting other people as well. So we do see a difference there.
And we've done a study on our program supporting adults with polycystic ovary syndrome to look at a correlation between the indices of areas of deprivation where they live, because we had much higher percentage actually on those courses. We had 26% people from the lowest 30% deciles, and we were looking whether that impacts engagement. And actually from it wasn't a massive sample, but from what we've seen, we didn't see impact on people completing the program or progressing through the program in that group. So actually, this is some of the stuff that we are looking at more and more as to how we can make sure that nobody feels excluded and people benefit most. But it might be in different groups and different elements. But in terms of long-term conditions, that is our focus. And generally, people have been very positive, as Andy said. But like he said, the carers and parents have got multiple other responsibilities. So focusing on their health doesn't come naturally to us when we also care. And
we find it's more challenging to recruit men initially onto the programs, but once they've signed up and progressed through you know, at least one session, they're as likely or more likely to engage fully than female participants. So that's the challenge. You know, one of the challenges, how you get men to kind of look at the recruitment adverts and think that speaks to me. I'm going to give this a try.
Thank you. It's really interesting regarding the sort of social deprivation and the fact that you're not finding that correlation within your small samples, particularly with Coventry.
Yeah.
In fact, I think one of the researchers at Coventry University, Dr. Carol Percy, who developed the PCOS program, she is doing a stakeholder meeting in the next couple of months, and particularly to look at the minoritized participants. So she's collaborating with a group that supports minoritized women, and you know, to really get a sense of, you know, what needs to be in the program or what needs to be taken out of the program and the recruitment to make it more attractive.
Thank you very much. So just one more question from me. I don't know if there are any other questions from anybody. So I just wanted to ask how you recruit people to the program. So is it by referral from your partner organizations, or can people sign up individually, say they want to get something from the program?
So it is both, Michael. So people can, we don't really have formal referral relationships. The partnerships with organizations tend to signpost people to the program, so to offer them a choice. So individuals can sign up to any of our programs. It is their choice at the end. We have worked in the past with the short trusts when we offered the program for people who were out of employment, where it was through a referral route. So again, it is flexible. But we know that if people do make that choice, or if it's signposted to them by a health professional, they are more likely to stick with going through the course, because we all will be slightly skeptical about something being offered to us in this way. Maybe potentially doesn't speak to us, but really flexible models of signs up. But that's why we don't do. It's not necessarily the HOPE program. You will hear about the Macmillan Cancer Support HOPE program, the NHS HOPE program, the RH HOPE program, because it's organizations that people trust delivering those programs rather than us as HOPE for the Community. We sit in the background, and we're very happy to do that, because what we want to see is that benefit to the people at the end, and that you know, impact, hopefully positive impact on their lives.
Thank you very much. Very helpful. If there are no other questions, I guess we've come to the end of the session today. Thank you very much, Gabriela. Thank you very much, Andy. And thanks for everyone who stayed. Even though we've gone over time, I apologize for that. And we hope it's been very helpful and that you've learned a lot. Goodbye, everyone.
Thank you very much.
Thank you very much.
Everybody.
Thank
Thanks
you,
for
everybody.
attending. Thanks, Michael.
Thank you. Thank you, Natalie. Bye. 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 Oh, very good.
Very good. See you, Michael.
Thank you very much, Michael, for organising
Yeah,
it.
no
Bye.
problem. That was a great
Bye.
session. Goodbye. Bye-bye.
Bye. Bye.